I am Molly Brown from the Heartland Telehealth Resource Center. We're glad you're joining us for the HTRC education series today, focused on telehealth billing, coding, and policy. Just a couple of reminders before we get started. The session is being recorded and we will share it with you afterwards. Your microphones have been muted. You can unmute yourself to ask any questions or use the chat to talk. I will be monitoring that as well. Your completion certificates will be emailed. It's important to sign on with your first and last name so we can identify you. You can rename yourself by using the 3 dots on your Zoom screen. I believe it's at the top right corner for your full name if it isn't visible. So let's get started. I'd like to introduce Rochelle Marting. Rochelle is a local attorney who is also a registered health information administrator and certified medical coder. Her practice focuses on medical coding, billing and reimbursement, HIPAA privacy and security, health information management, and regulatory compliance. We're thrilled to have her here today to talk about policy, billing, and guidelines around telehospice and telepalliative care. I will go ahead and turn it over to Rochelle to get started.
Right, thanks, Molly. So I was getting ready for this presentation, and it just reminded me as I'm going through some of Medicare's manuals and rules and requirements on just regular hospice coding and billing policies. And hospice is one area where the billing rules are just fascinating to me because they are so incredibly intricate. It's always intricate and detailed and nuanced. But if you were to review the I think it's 75 or 78 pages of the Medicare claims processing manual for hospice. It is 78 pages of bulleted items of very specific claim details that have to be on that claim. If we went back a year or so ago, we did a session going through the different fields of the facility claim form, the UB04 claim form. And hospice is one area that is just incredibly particular on the fields and the indicators and the values that go onto that claim form. So, of course, as we talk about how some of those things have changed during the COVID public health emergency and with respect to telehealth services, it just makes me think how complex and nuanced some of those claim submission requirements are. So for this afternoon, I'm going to go through some general guidelines with respect to hospice services that are particularly relevant when we talk about telehealth services in a hospice or palliative care program. And then look at some of the restrictions or rules, I should say, requirements surrounding hospice and palliative care services, even before the COVID public health emergency, that become important and that play a part in how we look at telehealth in the hospice and the palliative care setting, particularly with telehealth now. Then we'll look at the way the COVID-19 public health emergency has created new opportunities to deliver telehealth in this setting, and also clarified some telehealth opportunities that have always been there, but maybe not really clear or taken advantage of before the COVID public health emergency really propelled the use of telehealth in all areas, hospice and palliative care, certainly one of those. And then I'll go through some of the coding and billing requirements specifically for hospice telehealth services, from kind of the whole workflow of when you're doing the pre-education and counseling, to the certification of terminal illness, to the notice of election, and all of those steps, and the attending physician services, and what the coding and billing looks like. And we'll kind of talk about how the telehealth nuances do or do not come into play in each of those steps. So let's talk about just kind of the general guidelines for hospice and palliative care that are going to set the stage and the framework for how some of those services can be transitioned to telecommunications technology. One of the requirements that or guidelines that we know with hospice care is that the standard of care, the consent process, the hospice selection, privacy, those are all going to continue to be important concepts whether hospice is being delivered in person or whether it's being delivered, or a portion of the services are being delivered via telecommunications technology. And as I'm saying that out loud, there's one point I want to emphasize here at the beginning, and I'll try to make sure I keep my nomenclature straight. When I say face-to-face services, those are often things that tend to be prime for either in-person or telecommunications technology. So if we're talking about a standard or requirement that refers to a face-to-face service, face-to-face can also include audiovisual technology in many instances. And we're going to take a look at some examples of that. If I'm using the term in-person services or a requirement that uses language about an in-person visit or exam requirement, those are requirements that tend to actually require a literal in-person face-to-face service rather than telecommunications technology. And we'll take a look at some examples on where we may have some flexibility on those. So I'm going to start kind of at the beginning of this process for hospice and palliative care in the way that they can potentially establish a hospice or a provider-patient relationship with a patient who may be coming into hospice care and electing hospice coverage. And this is a little bit different state to state. It's also a little bit different as states' emergency statuses have come and gone. We've now got bills in different states that might be changing some of these requirements now that we've got more experience with telehealth. So this is as of today, or at least as of yesterday, when I was putting this information together, what those requirements look like. So starting with Kansas, providers, including hospices, can establish a provider-patient relationship using telemedicine. So then we have to look at the way telemedicine is then defined, because the definition of telemedicine tells us when and how and in what ways that provider-patient relationship can be initiated. So in Kansas, that term telemedicine means two-way interactive audio, visual, or audio-visual communications. And I have a couple of those terms bolded because I think we're familiar with audio-visual, like we're engaging in right now during this session. You can see me, you can hear me, and it's real-time two-way communication. However, in Kansas, telemedicine can also mean an audio-only communication. So you see that or is any of those three can be a telehealth communication or a telemedicine service or communication. In Kansas, it could also potentially be store and forward technology. But these are the two. The audio visual is the primary way we think of the modality, but audio only has been a real focus as flexibilities are starting to, or we're starting to see maybe potentially light at the end of the tunnel in terms of the public health emergency. I almost hesitate to say that because I think I said it last July and then things got really crazy again, like 2 weeks after I said that. So I use that term very cautiously. However, Kansas law is clear though that email and fax are insufficient to establish a provider-patient relationship through telecommunications technology. So I think the key there is the real-time two-way communication is a key to that. So email and fax that are asynchronous would not be sufficient to establish the relationship. So crossing the state line over into Missouri, this has been a subject of a lot of discussion as December, I want to say 31st, if I remember correctly, the latest emergency declaration in the state of Missouri ended, which got rid of a lot of the, or could have gotten rid of a lot of the telehealth flexibilities. However, the Department of Health and Human Services in the state of Missouri subsequently, about 2 weeks later in January, issued some clarification on the impact of that state emergency declaration ending and what that meant for telehealth in the state. So by statute, even outside of the state's emergency declaration, even outside of the federal public health emergency, in Missouri, the state defines telemedicine and says that the provider-patient relationship can be established by a telemedicine encounter so long as under the circumstances, the standard of care doesn't require an in-person, so see that phrase in-person encounter, and that telemedicine encounter would be consistent with evidence-based practice. Basically, it's appropriate to establish that relationship via telemedicine. This is kind of a subjective standard, so it's really up to the provider's professional judgment on whether it's appropriate under the circumstances to do that. Now that establishing the provider-patient relationship via telemedicine during the state's emergency declaration, there was guidance from the state agency that could be done via audio only. So there was concern December 31st when that went away, whether the ability to establish a provider-patient relationship by audio only would also go away. And we were kind of left in the dark for about 1 to 2 weeks until we started to see some guidance come from the agency that said, for the time being, at least, there wasn't a plan to change that ability for the provider-patient relationship to be initiated by audio-only services. And at the end of this presentation, there's a resources page, and there are a couple of bullet points where you can find this information. It's on the Missouri Department of Health and Human Services website under a hot tips section that's posted on their website. And then there was subsequently a written memo from the Missouri Department of Health and Human Services to Missouri hospitals. Not sure why just hospitals, but it was regarding the telehealth laws in general, not just specific to those in hospitals, clarifying that piece. Another caveat to initiating the provider-patient relationship by a telemedicine communication system in Missouri is that technology has to be sufficient to establish an informed diagnosis. Okay, so I think that kind of ties into it has to be consistent with the standard of care. Sufficient enough to establish that diagnosis as though the medical interview, as though the physical exam has been performed, there's that phrase again, in person. That bolded language was really what caused a lot of concern that absent this kind of administrative guidance that this could be done via audio only, there was concern that this statutory language was implying an in-person physical exam had to be done in order to establish the provider-patient relationship. And the guidance that has come out since that emergency status ended said, no, that's not necessarily true. So as long as the visit is clinically appropriate, there are certain physical exam objective findings that you could perform via a telecommunications technology. Depending on the modality, for example, you could have the patient self-report their weight, their height, then you can calculate BMI. If they have a blood pressure cuff at home, you can coach them through counting their respirations, their pulse. And all of this, of course, could also be done with the caregiver present, helping with some of these services in the hospice or palliative care environment. So things like that, observing signs of pain, if the patient is guarded, if they're wincing in pain, when you coach a caregiver through, palpating different parts of the body and asking whether that's causing pain to the patient. Physically observing the skin, looking for modeling of the extremities, and those types of things can all be done watching the patient breathing, looking for any signs of labored breathing as you observe the patient. So there are a lot of physical exam components that can potentially be done through telecommunications technology and documented as well. Then in our statutes in Missouri, and again, this is not limited to COVID public health emergency, these are just general telehealth rules in Missouri. Consulting with a professional who consults with another provider, where that other provider already has an established provider-patient relationship and the consulting provider agrees to participate in the patient's care, that can also establish a provider-patient relationship. However, the flip side of that, an informal consultation between providers where the kind of the curbside consult, hey doc, hey colleague, I've got this thing going on with a patient, what do you think? And the provider says, oh, check into this, maybe this, consider trying this. That kind of informal consult where the consulting provider hasn't agreed to accept responsibility for the patient care, that does not establish the provider-patient relationship. So I'd also add that while those two nuances are actually written into the statutes in telemedicine in Missouri, it really is a concept that applies to the provider-patient relationship in general, regardless of the modality of the services that are being provided. And then heading south to Oklahoma, the statutes in Oklahoma say that the provider-patient relationship can also be established by telemedicine in the state of Oklahoma, however, not by audio only. So that's going to be a key difference between the Kansas and Missouri rules and what you all are working under in the state of Oklahoma. However, there's a caveat. In Oklahoma, telehealth cannot be used to establish a provider-patient relationship merely for the purpose of prescribing certain controlled substances that fall within those categories. Let's see. I guess this next bullet point, that the provider's professional responsibilities, the duties owed to a patient, don't apply until the physician affirmatively undertakes to diagnose and treat the patient. Again, that's not really unique to telehealth, although it is written into the telehealth rules in the state of Oklahoma. And I had to smile a little bit. I'm actually going to pull this slide for my next class that I teach in our master's program at KU, because we were just talking about establishing the provider-patient relationship and how that works, and that it's really a contractual relationship where there's a mutual agreement to undertake responsibility for the care and management of the patient. Because once a provider does that, there's now a duty owed to that individual, and that's an important element when it comes to negligence or malpractice. So these rules on establishing the provider-patient relationship in the states, I want you to keep in mind as we look at some of the CMS, the Medicare flexibilities for hospice services in just a little bit. Thinking about the kind of the workflow and the flow and the sequence of events in a patient electing hospice care, there's a quote from, let me think, this comes from a Medicare Telehealth FAQ document that has been published to give guidance on telehealth rules and flexibilities during the public health emergency. It's also at the end of this presentation on the resources page. But there's a good quote that I like that says typically an in-person initial and comprehensive assessment is the standard of practice, and it's crucial to establishing the patient-hospice relationship. So when we go back to all of these rules and requirements on how professionals may establish the provider-patient relationship in the states, there's this concept under the Medicare rules for a hospice establishing a relationship with the patient, where that initial assessment that typically is in person is a critical element of establishing that relationship with the patient. But again, I'm going to put a little asterisk next to that in-person language here, because we're going to see how that's changed a little bit during the public health emergency. Okay, so establishing the provider-patient relationship, and a part of that is the patient's consent. Consent not only in electing hospice and the hospice notice of election, but also consent to using telehealth as a modality to delivering hospice services. So consent has some different elements depending on the state, and also has some requirements under Medicare, Medicaid billing programs. Kansas and Oklahoma are not specific or prescriptive on how consent works with respect to telehealth services in particular. Oklahoma has some rules about consent for telehealth in the school setting, but that's probably not going to come into play in the context of hospice and palliative care. In Missouri, though, our statutes on telehealth services require that when a service is being done via telehealth, providers must obtain consent before the telehealth service is initiated. And so there's a timing element there that we have to get consent before we're actually on that audio telecommunications technology or that audio visual telecommunications technology, typically. That's kind of our default statute. During the public health emergency, Medicare, which also typically requires that consent happen before the telehealth service begins, has a flexibility saying that you could get the patient's consent at the time of service. So depending on the timing of events, if you're on the phone or in an audio visual platform talking to the patient's family and caregivers about hospice services, Medicare says that may be okay, and you can get the consent at the time you start that service. However, even though Medicare has that requirement during the public health emergency, Missouri still has its statute saying that consent has to be obtained prior to when services are initiated. Part of the consent, particularly with respect to telehealth services and telehealth in the hospice and palliative care context, is that telehealth may not be secure. There's no guarantees of the security or privacy of the communication, and we want to make sure we're still documenting it. Even if we're not having a dedicated consent form signed for telehealth services, rather we're doing it at the time of service. For those of you in Kansas and Oklahoma who could do it at the time for Medicare during the public health emergency, you still want to document that the patient has given consent, patient or caregivers have given consent to proceed in the telehealth format. So privacy and security of telehealth services in the hospice environment, it in general follows many of the same privacy and security principles as other telehealth services. The Office for Civil Rights has issued guidance during the public health emergency that it, as one of the enforcement agencies or with authority to enforce federal HIPAA rules, would not impose penalties for providers who are using non-public facing applications to deliver telehealth. So that may be like FaceTime on your phone or Zoom or other platforms that maybe don't have the higher level of security like the HIPAA I'm trying to think of subscription that you could purchase from Zoom versus say just the free version of Zoom that's available to consumers. I would add, though, that is only the Office for Civil Rights that has relaxed that HIPAA security requirement in a very, very narrow way. HIPAA privacy, HIPAA security rules are still in effect during the public health emergency. They very much apply to telehealth services. And there are other enforcement agencies like the state attorney generals that could impose enforcement actions for those same things that Office for Civil Rights said that they would not enforce penalties for. So we're not really out of the woods, so to speak, if we had a security event surrounding some of those applications, especially now that we've had more experience with telehealth and we're using telehealth in hospice and palliative care more. If you haven't already, I think it'd be a great idea to make sure that the platform that you're using is designed to be used for healthcare services and has additional security safeguards that are expected under the HIPAA security rules. Outside of security, though, there's the concept of privacy and confidentiality under those federal rules. So we've got HIPAA, of course, that dictates the privacy of information, state law requirements that sort of reiterate how that works for HIPAA. And we also have under Medicare, the patient has a right to the confidentiality of their health information and their medical information, their medical record as well. So under HIPAA, there are a couple of provisions on the privacy side that I think are particularly relevant in the hospice context. And one of those privacy issues is that the individual that we can share information with, the patient himself or herself, of course, is the primary holder of the right to decide what happens with their health information. In the hospice and the palliative care context, we're often going to have friends, family, caregivers, surrogate decision makers, durable powers of attorney for healthcare decisions involved in that process. We may be working with other healthcare providers. And so understanding what the HIPAA rules say about talking with those individuals about the patient's care, treatment, and payment for services is really important. HIPAA has a provision, and I think when my grandfather was in a hospice house, this was a really good example, I think, where the family's in the room, and boy, did we fill that room up with family with him. And the nurse or the physician comes in to do their evaluation under the hospice program. And, we've got 15 people in the room there with the patient, right? So from a HIPAA perspective, there are provisions that allow the healthcare provider to have a conversation about the patient's care and treatment when the patient is present and friends, family members, or others in the room. And the provision says that as long as the patient doesn't object and has an opportunity to agree or object, then that's fine to talk about the patient's care in the room with all those other individuals. Great, a good practice, particularly if you're talking about, maybe new lab findings, maybe new imaging findings, things like that, that might be sensitive, or if part of the physical exam may be kind of a private exam that needs to happen, asking the patient, asking the next of kin or caregiver, surrogate decision maker, do we want to have this conversation with everybody in the room, or would you like for it to be private, is fine. But that provision of HIPAA, as long as the patient is present and has the opportunity to agree or object, allows us to have that conversation. In the telehealth context, that just means that when we're having the telehealth visit with the patient present, that if friends, family members, caregivers, surrogate decision makers are also in the room or in a place where they may be able to overhear that telehealth conversation, that we maybe do an inventory about who do we have in the room with us. And because the patient's present, as long as the patient doesn't object, patient, Sally, are you okay if we have everybody in the room while we have our visit? Patient or decision maker says that's fine, you can proceed. There is some question, though, about what happens when the patient is present, but maybe not competent to provide that consent or objection to those in the room being present during the telehealth service. And there are a couple of provisions of HIPAA that would still allow you to provide a telehealth service with other caregivers, friends, family, decision makers, even when the patient cannot object despite being physically present during the telehealth service. If we have the individual who has the authority by law when the patient is incompetent to give consent, and that individual steps in the shoes of the patient and gives that consent, then that's fine too. The other provision of HIPAA that allows us to do it is that if in the provider's professional judgment, they don't have any reason to believe that the patient would object, if wife, children, parents are also in the room during the telehealth visit, then that's fine to proceed as well.
Rochelle, we do have a question in the chat.
Sure.
Do you have recommendations for the best platforms, I'm assuming related to privacy and security, that could be used? For this question, they use multiple Doximity, Cerner, and Teams, or maybe if there's a resource link or something they could link to find the list of preferred or recommended platforms that might be helpful.
Okay, so that's a great question. When the Office for Civil Rights announced that it was waiving its enforcement discretion to impose any penalties if you are using a non-public facing application like FaceTime or Zoom. Compare that to like Facebook Live feature, right? That is broadcast publicly on someone's account. But non-public facing visit. The Office for Civil Rights has also been pretty clear, though, that it doesn't endorse or certify any particular platform. So when you go out and you're looking, I'm going to pick on Zoom, and I don't know all of the details of Zoom's security features or contract, but I'll use it just since that's what we're using for this session. If you were to go out to a vendor like Zoom and their website says their platform is HIPAA certified or HIPAA compliant, there is no such thing right now as a HIPAA certification for a security compliant platform. That just means the vendor is self-representing that they meet the HIPAA security requirements. So the key when you're looking for the platform, I think one of the very first questions that you should ask before you get down the contract too far is, where will that vendor enter into a business associate agreement? Do they have a subscription or a platform option that is designed to be used for healthcare and follows the HIPAA security rules? I think that's the very first question you ask. And if the vendor says, well, no, not really, or we don't sign business associate agreements, that's going to be the flag that that's probably for the long term, after the federal public health emergency ends, not going to be the platform that you want to invest in long term from a security standpoint. There is no single list of vendors that that I would say are preferred by any particular agency. You can do some searches of vendors that have had fewer or more incidents that might kind of be an indicator to you on which ones might be better suited for your particular needs. Another thing, a lot of people are familiar with certain applications versus others that may create more challenges or difficulty in the patients and their family accessing. So that's certainly a consideration as well, because you have to be able to access it, but what is the mechanism? Does the patient and their family have to download something, or can they just follow a link? And those types of things on whether there's a mobile version, just a desktop version, and how your patients need to be able to access it and what various platforms have available.
There's a second question about consent. What is the best format for the consent form? And does the consent need to state that services are provided due to the fear of COVID for the consent to be valid? There has been some talk in compliance world that consent needs this verbiage based off the link below. And then there's a link in the chat to CMS website related to these questions.
Okay, I'm going to follow that link really quickly. So in terms of the consent containing certain language about the reason for the telehealth service being delivered, the hospice service being delivered by telehealth due to a concern related to COVID is really not a requirement when we're looking at the coding and billing requirements in just a bit, in order for the services to be permitted to be covered in a telehealth modality. There may be certain programs and types of services outside of the hospice context that may be a requirement, particularly for services that ordinarily would be in person, not face-to-face, but in person. And in order to exercise the flexibility to do those via telehealth, and I can't think of an example off the top of my head, but there may be service-specific requirements in some situations that the consent may need to contain that language. I did not see, in preparing for this presentation, that requirement with respect to these hospice services, but I certainly will explore that link after our session today and see if I can find anything particular in the FAQ from Medicare, particular to these services. The broader question on the ideal form and format for a consent is that generally doesn't even have to be a full page document in order to get the patient's consent for telehealth services. And particularly if it's being done at the time of service, with the exception of Missouri, because Missouri says it has to be before, but Kansas, Oklahoma, Medicare generally, if you're doing it at the time of service, just documenting that the patient agreed to proceed via telehealth service, or patient was advised that this would be via telehealth and agreed to proceed. There are some requirements for certain services, not really specific to the hospice context, that if we were doing an audio only versus audio visual, there would be some additional documentation requirements for that. So the language for your consent, the big piece is that you have it, that the patient agrees to proceed via telehealth. I would suggest some language about the patient or family understanding that telehealth may have some limitations, some inherent limitations, such as limits on the physical exam that can be performed, that telehealth is not necessarily the most secure form of communication. Even that's particularly important if you're using platforms like the free version of Zoom without a business associate agreement. After the PHE, we really need to be having platforms where we've got a business associate agreement and all of the security requirements in place. Those are really the three pieces that you want to have in a consent, whether that is just kind of an initial introductory statement during the telehealth service that's documented as part of the progress note, or if at the time of scheduling the service, a consent that can be filled out electronically or a hard copy that the patient fills out and signs. Those are kind of the three key pieces that you would want to consider having in the consent. As well as thinking about who's giving the consent and making sure the individual signing, if our patient is not competent or physically able to sign, that the person signing consent has the authority to do that on the patient's behalf. So in terms of the standard of care for telehealth, the first citation here is Medicare rules for telehealth, and says that a telepresenter is not necessary or not necessarily required unless it would be appropriate under the circumstances. That means if we're having our telehealth visit to a patient at home for hospice services, we don't necessarily have to have a nurse physically present with the patient and family at home to present or kind of administer the telehealth session. And then under Kansas statutes, it's specific that the same standards of practice for an in-person service applies also to telemedicine services. And then this is kind of just touching on that last piece, the accessibility in terms of the platform that you're using. How do patients or caregivers access it? By phone, by computer? Is it a link? Do they have to download something? To just consider how easy and accessible it is for those individuals to use. Okay, so now I'm going to get into some of the pre-pandemic coverage rules for hospice that really come into play when we talk about the flexibilities for telehealth in the hospice environment. So kind of walking through the steps of electing hospice and getting into hospice care, we have a pre-election evaluation and counseling service. The requirements for that, both prior to and during the PHE, that is furnished by a physician, employee of the hospice, or a medical director of the hospice. However, while the hospice may bill for that service, the code that's used for it is not on the CMS list for services that can be rendered via telehealth. So even during the PHE, that one hasn't been expanded as a telehealth service. So then we have the certification that the patient meets criteria for hospice care, which really is certifying that the patient has a terminal illness that would be eligible. So all the rules surrounding that are in federal regulations. Has to be done at the beginning of the first benefit period, the first 90-day period, each the subsequent 60-day, and then every 60 days after. Now, seeing this language, that certification has to be face-to-face if the patient is reaching the third benefit period. Face-to-face is used, not in person. So that becomes important with our options in telehealth. Has to be done by a hospice physician or hospice nurse practitioner. Now, I highlight that because if you look 2 bullet points down, there's a difference in requirements on who can serve as a hospice attending physician under Medicare rules, doc, APRN, or physician assistant. However, the certification has to be done by a physician or APRN. Physicians are not eligible under the Medicare program to do the certification that the patient has a terminal condition. Now, I think this last quote, I've got it a couple of times in this session because this comes from, let's see, where does it come from? The March or May 2020 interim final rule for Medicare, when a lot of flexibilities were coming out very quickly, that says nothing in the statutes on hospice, even before the public health emergency, precludes the hospice designated physician from furnishing services via telehealth. So Medicare is taking a look at all the regs and says, gosh, when we see language like face-to-face, there's not a statutory restriction that would prevent that from that face-to-face service from being audio-visual or telehealth. So the timing of that initial certification generally has to happen before the hospice is submitting its first claim for services, but can happen earlier, but no more than 15 calendar days before the effective date of the patient's election of hospice care, or 15 days prior to the next benefit period. There is a provision under the regulations that is explicit that if prior to the third benefit period, the recertification that we still think the patient has a terminal illness with a typical prognosis of 6 months or less, that recertification prior to that third benefit period can be done via telecommunication technology. It doesn't preclude the previous certifications from being done via telecommunication technology. It's just that the regulation outside of COVID says that particular certification must be face-to-face, meaning the other certifications don't necessarily have to be face-to-face. That one does. And during the public health emergency, that particular certification that has to be face-to-face can be telecommunications technology. The catch is that it's considered an administrative expense of the hospice. It's not a separately billable service outside of the per diem payment. However, we're going to look at the way that the hospice can capture that still on its cost report in just a bit. Okay, so regardless of the modality of the certification being in person, face-to-face, or telehealth, keep in mind that there are really specific content requirements for the certification. And this is where it just always amazes me how nuanced and particular hospice rules are. So I pull this as an example because I just think it's interesting that in the rules, the placement of certain language on the certification documentation is also spelled out. So if the narrative is part of the certification, that narrative must be immediately prior to the physician's signature, not after, not 2 paragraphs before, but immediately prior to the physician's signature. And if you look at these requirements in the Medicare manual, it is just so incredibly specific on exactly what needs to be in that certification and where in the certification that we still have to follow, even if it's done via telehealth. And then we have signature requirements on who has to sign off on that certification. So this is from back in, and I apologize, I can't remember if this was March of 20 or May of 20 interim final rules. I believe it was May, where Medicare says that the statute on hospice services under the Social Security Act, it's silent as to whether a face-to-face encounter that is solely for the purpose of recertifying the patient's eligibility for hospice care can be conducted via telehealth. So given that a face-to-face visit solely for the purpose of recertification is considered an administrative requirement, we believe that it can be done via telehealth. Okay, telecommunications technology for that purpose, because of the language face-to-face, requires audio visual and cannot be done via audio only technology. So now I'm going to talk about the hospice attending physician requirements, both under Medicare and under state law, because there are some variations here that are important that then translate into how we deliver those attending physician services via telehealth and how we may or may not be able to bill for them. So Missouri, you all have some requirements that are more restrictive than in Kansas. I should say Missouri and Oklahoma have this restriction. So in Missouri, the rules for licensing a hospice define what a hospice attending physician is, and that has to be an MD or a DO. It cannot be a nurse practitioner. It cannot be a physician assistant. That is different than the Medicare definition of a hospice attending physician. So Missouri and Oklahoma, your rules are more restrictive than what Medicare would allow because of our state laws and state regulations. In Kansas, though, the definition of an attending physician for hospice aligns with Medicare in that it can be an MD, a DO, a nurse practitioner, or a physician assistant. And in all of the states and in Medicare, regardless of what the credentials are, it's the provider that the patient designates as having the most significant role in the patient's care under the hospice program. So let's talk about flexibilities specific to the public health emergency, specific to hospice care, that allow us to use telecommunications more in the hospice and palliative care setting and in this context. So under the Medicare rules for hospice care, we have flexibilities during the public health emergency specific to routine home care, that level of care under hospice, that those hospice services can be done via a telecommunications system. However, in order to do that, it must be documented on the plan of care that telecommunications services are appropriate and part of the plan for that particular patient getting routine home care. That flexibility is specific to the routine home care level of hospice services, not respite care and not general inpatient care. So I think that's important to keep in mind. It's fairly limited. In the plan of care, when it's documented that telecommunications is part of that patient's plan, we also have to tie that to patient-specific needs as identified in the comprehensive assessment. And remember, in establishing the hospice patient relationship, Medicare has said that an in-person comprehensive assessment is really integral and essential to establishing the hospice patient relationship. So that needs to be addressed in the assessment and in the plan of care, and described in the plan of care how technology will achieve goals outlined in the plan of care. I think these elements, if they are to become permanent outside of the public health emergency, like the professional associations that are advocating for that would like to see, these are the areas that I think would be prime targets for in program integrity reviews, meaning chart reviews and audits to look to see if providers have met the expectations. And if these things aren't specifically called out in the plan of care to deliver via telehealth, tied to patient-specific needs in the assessment, describing how it will achieve goals, that's where I envision hospice providers may stumble a little bit in terms of program integrity and being able to retain payment for some of their hospice services delivered via telecommunications technology. So some home health and hospice specific FAQs on using telehealth during the public health emergency. Can hospice furnish hospice services, the way hospice services are defined under the Medicare rules, via telecommunications technology? Yes, they can. This can also include telephone calls or two-way audio video communications technology. It's up to the clinician's professional judgment as to whether that can meet the patient and the family's needs. And again, it has to be included in the plan of care to be able to do that. Can hospice physicians or hospice nurse practitioners conduct their required face-to-face encounter for recertification, so that when the patient's getting ready to enter the third benefit period, when it specifically has to be face-to-face under the Medicare rules, even outside of the public health emergency, could that recertification be done via telehealth? Yes, Medicare said they're allowed to use telehealth to satisfy the face-to-face requirement. And here this may have been what was in the chat, an explanation of why the findings support the patients, that the patient still has a life expectancy of 6 months or less, needs to be documented as part of the recertification. But because of the face-to-face language in the regulation, that particular recertification cannot be done via audio only, while other hospice services can potentially be done via audio only. Can those hospice services provided via a telecommunications technology, which can include audio only, except for the face-to-face requirement going into the third benefit period, can they be included on the hospice claim? And the answer to that is no, they're not included on the claim form itself if they're done via telecommunications technology. It's considered an administrative expense. And then keep in mind, for purposes of the service intensity add-on payments towards the end of a benefit period, only in person. So in person remember means physically present in the same location, are the only things that qualify for the service intensity add-on payments. However, there's really, let me go back. There's really specific requirements on what a hospice can do in capturing those telehealth hospice services on its cost report, even though they're not reported separately on the claim itself. The initial and the initial comprehensive assessment that we talked about. Remember that language where Medicare said it's really essential to establishing, here we go, it's standard practice and crucial to establish the patient-hospice relationship, to have that be in person. However, recognizing unusual circumstances during the public health emergency, Medicare said that if the hospice patient is receiving routine home care, not respite, not general inpatient, that it could potentially be delivered using telecommunications technology that would be compliant to the extent that that technology is capable of actually making possible a full assessment. Now, look at the bottom there, though, that if that's being done routinely, that could potentially be a problem. Medicare says we really expect this to be in person. However, given the circumstances, it's possible for that to be done via telehealth. We still expect most, but not all, initial comprehensive assessments to be done in person. All right, so let's look at some of the nuances of coding and billing for hospice services, particularly telehealth services during the PHE and beyond. One of the things to keep in mind, in particular for the professionals who may be separately billing for their hospice attending physician services or services that are unrelated to the patient's hospice diagnosis. In terms of enrolling with Medicare from the place where they will be delivering their distant site telehealth service, right now, the provider does not have to, if they're rendering those services from home, they don't have to register their home as a practice location with Medicare. However, even during the public health emergency, if the provider is regularly delivering services from some other location other than their home, they do need to register that practice location on their Medicare enrollment. It's the 855I, I believe, for 855B is the group practice, 855I is the individual enrollment form. Section 4, you would add that location where the provider is routinely going to be delivering their telehealth services as a registered practice location so that that can be reported as the location of service on the claim form towards the end. I want to say it's box 31 or 32. After the PHE, we're not really sure what those enrollment requirements are going to look like. So we'll be kind of waiting to see what the guidance looks like on providers delivering telehealth from their home and whether they will have to register their home as a practice location with Medicare. So again, that pre-election evaluation and counseling service is not on the CMS list of telehealth services that can be delivered and billed as a telehealth service. The certification, I think it's interesting here that, let me go back. In the interim final rule, it was clear that the certification going into the third benefit period can be done via telecommunications technology. And the reason I think that was called out is that the regulation says it has to be done face-to-face ordinarily. And so Medicare is saying, yeah, but that face-to-face is not the same as in person. So we believe that can be done via telehealth. In terms of the initial certifications or the recertification in the second benefit period, before going into the third, there's no requirement under the regulations that those have to be done face-to-face or in person. So the language you see here, this is outside of the public health emergency. The certification narrative says that the patient meets criteria, they have a terminal illness based on his or her review of the patient's record, or if applicable, his or her exam. So even outside of the public health emergency, under the Medicare program, there's not a requirement that that be done face-to-face or in person. Interdisciplinary group services are hospice services that can be delivered via telecommunications technology. They're not separately billable. They're considered administrative services, but they can be captured on the hospice cost report. So again, there's no separate payment outside of the per diem for these hospice services delivered via telecommunications technology. There's the rule or the very specific requirements on where you would report those on the hospice cost report. Now, this is where it gets a little bit nuanced in that the hospice attending physician services are separately payable services under Medicare. And those are services that can be rendered via telehealth under the hospice program. Now, remember that the attending physician services are the provider with the most significant role in the patient's hospice care. Medicare allows that to be a doc, a nurse practitioner, or a physician assistant. Kansas is the only of our 3 states in the HTRC that also allows APRNs and PAs to be designated as the patient's hospice attending provider. Missouri and Oklahoma, it's got to be an MD or a DO. So in Missouri and in Oklahoma, if there is a nurse practitioner working with the hospice, his or her services are not hospice attending physician services. They're considered nursing services and are not separately payable. So we could spend a lot of time going through the contractual requirements for those attending physician services. An independent, meaning not employed by or under arrangement with a hospice, independent attending physician can separately bill a MAC, the Part B MAC for Medicare, for the hospice attending physician services. There's some claim requirements if there's a service that involves both a professional and a technical component, that the technical piece, that independent physician would look to the hospice for payment for those services. In terms of some indicators on the place of service, if it's an independent physician billing separately for the professional services, they're going to bill just like any other professional telehealth service. They're going to use the place of service that describes how that visit would have been provided if it wasn't done in a telehealth form. So place of service 11 for the patient's home, for example. After the PHE, we're going to be using place of service 0, 2, or 10, depending on the payer, really, and depending on whether or not that telehealth service is delivered to a patient who is at home. There's also a modifier if a telehealth service is delivered to a patient who has elected hospice, but that telehealth service is unrelated to the patient's hospice condition, then there has to be a modifier GW added so that that unrelated visit can be paid for separately outside of the hospice per diem payment. And then lastly, these flexibilities allowing hospice services to be delivered via telehealth, the recertification being delivered via telehealth, national associations in hospice and home care are really pushing Congress to make those permanent flexibilities for telehealth in the hospice and palliative care setting. So there was just an announcement about a month ago that they continue to urge Congress to make that a permanent flexibility even when the public health emergency ends. So if you want to check out those professional associations and what they're advocating for, and write into those associations if you have interest in pro or con telehealth and the hospice programs, those would be the ones to connect with. Got some resources here on some of the citations that I've referenced during this presentation and links to documents that you can pull up and reference those materials. I'll pause there because I know I'm 2 minutes after the hour per usual. That's just how I run with these sessions. And I know, Molly, you had a couple of announcements for everybody as well.
Well, Rochelle, you cover a lot of information in a very short period of time. So thank you for that. As a reminder, we will be sending out the slides and webinar recording as soon as we get that stuff wrapped up. We will also provide the question regarding consent after Rochelle has a chance to look over that link a little bit more time. But I do have 2 announcements to be mindful of. We hope you can join us for the first HTRC pop-up webinar scheduled for next Monday, March 21st at 11. Our guest today, Rochelle, will be covering telehealth flexibility extensions, which Congress passed last week, and I believe is going up for signature by the president if it hasn't already. Join us to learn about these extensions and how they can impact telehealth services. If you have not received information to register, I did put the link in the chat, or you can email our htrc@kumc.edu for more information about that. Then we also have our regularly scheduled webinar on March 30th at noon, and Rochelle will be covering long-term care service delivery and billing. So thank you so much for attending, and look for us in your email. And again, click that registration link for the pop-up on Monday to learn more about those telehealth extensions.